At the end, we will discuss about the clinical cases related to the Mobitz type 1 heart block and this Mobitz type 2 heart block. First, we will discuss about the first scenario. An 80-year-old man is brought to the ER after syncopal episode. He has no chest pain or dyspnea but has severe constipation of recent onset. Was hospitalized 2 weeks ago for atrial fibrillation with a rapid ventricular response and was discharged from the home with oral medications for the appropriate management. His past medical history is also very significant for the hypertension, for the COPD requiring oxygen therapy. His blood pressure is 105 over 60 mmFSD and pulse is 50 per minute. On examination reveals bilateral decreased breath sounds, no wheezing and normal heart sounds. ECG show new onset second degree AV block. Which of the following is most likely cause of his current medication? Drugs include this. Now patient presents to us with syncopal episodes. The patient has a severe constipation from the recent onset and on the previous admission to the hospital. Patient 2 weeks ago, patient diagnosed with atrial fibrillation with rapid heart response. It's mean we discharge the patient on such medication which control the ventricular rate. It can in the atrial fibrillation to control the ventricular rate rhythm. Do the we give the medication like calcium channel blockers, beta blockers, in some cases digoxin and amiodarone. The most common drugs are the calcium channel blockers and the beta blockers. So patient may be given among these two groups of the drugs and pass. Also patient is also has hypertensive and severe COPD. So and also patient is symptomatic with hypertension, bradycardia and bilateral decreased heart sound as patient is COPD. ECG show the second degree heart block. Now the drug which is causing the syncopal episode, the severe constipation and bradycardia, we will choose one of these. Amiodarone cannot do the second degree heart block or cannot lead to the second degree heart block. Then there can be the indapamide is the thiazide diuretic. It can no effect on the heart. Then lidocaine is the sodium channel blocker. It does not affect to the AV node. Then is trazosine, which is the alpha 1 blocker, and it has no effect on the heart. Valsartan, which is the angiotensin receptor blocker, has no effect on the heart. We will choose one. It can be the propranolol or diltiazem drug, which is prescribed to the patient. Then, as patient is COPDic, patient has this severe condition related to congestive pulmonary disease. So patient cannot be prescribed with the propranolol as it can worsen the condition of COPD. So patient most likely prescribed diltiazem, which show the patient has constipation and the second degree heart block. What will be the management in this case? The patient, as patient is symptomatic second degree heart block, we will do the pacing, initially the transcutaneous pacing and later on the permanent transvenous pacing. And now we will move to the second our scenario. A 44-year-old man comes to the physician for routine health maintenance examination. He feels well. He underwent appendectomy at the age of 25 years. He has history of hypercholesterolemia that is well controlled with atorvastatin. He is an avid marathon runner and runs 8 miles per day 4 times a week. His father died of MI at the age of 42 years. Cardiopulmonary examination shows no abnormalities. His abdomen is soft and non-tender with a surgical scar in the right lower quadrant. Lab studies are within normal limits and ECG is shown. And which of the following is the most likely diagnosis? Now, patient is young, presented with this come to the hospital with routine maintenance health examination. Patient has history of hypercholesterolemia that is well controlled. Patient is marathon runner and runs 8 miles a week, and also has the history of myocardial infarction in the early ages. Then the findings, now we will see the findings on the ECG. As in the ECG there is the regular RR intervals, then there is the drop beat. So the pulse is regularly irregular. Then there is the prolonged continuous prolonged PR interval and after the block. So the on ECG findings it is a Mobitz type 1 block. Mobitz type 1 block, as there is the continuous increase in the PR interval, then the drop beat, and also the post block PR interval is shortened and pre block interval is prolonged, which is the typical findings in the Mobitz type 1 block. Uh, uh, the other options which include MI, it cannot be MI as there is no ST elevation. Third degree gravity block, as P is followed by QRS complex, and there is no dissociation between the P and QRS complex, so it cannot be the third degree gravity block. Then there is Mobitz type 2. In Mobitz type 2 there is the uh, equal P all the PR intervals, and then there is the drop beat, and also in the second degree Mobitz type 2 block, there will not the post block shortening of the PR interval. Then there is the first degree heart block, there is the no mid beat in the first degree heart block. In first degree there is only prolonged and similar equal prolonged and equal PR interval in the in all the QRS complexes.